Good morning, everyone, and welcome to the Osher Center for Integrative Medicine Grand Rounds this morning. So for those of you who may be joining us for the first time, this is a monthly series held the first Tuesday of the month that alternates between a clinical Grand Rounds and a research Grand Rounds. Today is a research-focused Grand Rounds with Dr. Rebecca Wells as our featured speaker. Before I further introduce Dr. Wells, a couple of housekeeping issues. So first of all, for those of you who are requesting CME credit for today's talk, if you can please refer to the details in the chat for instructions on how to request that credit. And secondly, I want to welcome and encourage everyone to ask questions of the speaker via the Q&A function in Zoom. So you can type in these questions at any time, and I'll do my best to organize and pose these questions to the speaker at the end of her talk during the Q&A session. Okay, so it's my pleasure to introduce and to welcome back to Harvard, Dr. Rebecca Wells, who is an associate professor in the Department of Neurology at Wake Forest Baptist Health Center in Winston-Salem, North Carolina, where she founded and directs the Multidisciplinary Comprehensive Headache Program. She also serves as an Associate Director of Clinical Research at the Wake Forest Center for Integrative Medicine. She's also a graduate of the Harvard Medical School T32 Research Fellowship in Integrative Medicine and received a Master of Public Health degree in Clinical Effectiveness from the Harvard Chan School of Public Health. She also completed a clinical fellowship in headache and facial pain at the Brigham and Women's Hospital. And Dr. Wells is currently the Vice President of the Southern Headache Society. She's on the board of directors of the American Headache Society, and she is a leading investigator in the field of mind-body approaches for headaches. So welcome, Dr. Wells.
Thank you so much. It is such an honor to be here today and it's like a homecoming of getting a chance to talk with you all. And it's really my honor and pleasure. And in a lot of ways, I'm just filled with so much gratitude for all of the people at Osher who gave me the experiences and knowledge base and research understanding to be able to do the research that I'm going to talk about today. So this research and this presentation is really a thank you to everyone who helped teach me how to do clinical research. So I'm really excited, and I am really hopeful for lots of questions and a discussion at the end. This is an open forum for asking me any details about the research or running the clinical trial that I did. It's just a real honor. So I'm going to share my screen. Okay, you got it? Lori, can you see? Okay,
yes.
So you can see it?
Yes.
Okay, great. So does mindfulness help migraine? What does the evidence show? And so this is really an exploration of the clinical trial that I conducted and the process and the results along the way. So I have no conflicts of interest. And so my goals today are really to discuss the background of research on mindfulness and migraine, and to discuss the recent clinical trial that we conducted, and then to synthesize and discuss these results. And like I mentioned, I'm really hopeful for a great discussion at the end about how we conducted the study and the results and the implications of them. So this research project really began in 2008 when I started my Osher fellowship. And then I got my master's in public health and graduated from Osher. And I have a couple of personal notes on here. I got married that same year in 2008. And after I finished the Osher fellowship, like Gloria mentioned, I then stayed in Boston and did a one-year headache fellowship. And then in 2012, I came to Wake Forest and founded our comprehensive headache program here and began conducting clinical research here in Winston-Salem, North Carolina. In 2014 and 2015, I submitted my K-23 and got funded, and also had 2 children. And so I joke, from the time that I put in my K to the time that I got funded, I had 2 children. And it's actually not a joke. My children are 18 months apart, and the timing was literally such that the funding, I put in my K, went out on maternity leave, came back, got the score, resubmitted, put it back in, came back from my second maternity leave, and got funded and started my research. and then conducted the trial over several years. And then just this last December, our results were published. And so here I am today giving you my talk. And so it's been a journey, but it all started at Osher. And I'm just so appreciative of all of the learning that gave me the opportunity to conduct this research. So I want to begin by just giving an overview of migraine. Many of you may not be aware, but 45 million Americans experience migraine, and it costs the US $14 billion a year. Migraine is more common than asthma and diabetes. And most people who have migraine experience such severe disability during an attack that it requires bed rest. Migraine is the second leading cause of disability worldwide. So not only is this a highly prevalent condition, but it's also extraordinarily disabling. I see that somebody raised their hand. I don't know. If you have a question, go ahead and throw that in the Q&A. So in terms of the need for non-drug treatment options, medicines can be very helpful, but often have side effects. And we find that in patients with migraine, they seem to be especially sensitive to medication side effects. Medicines aren't always 100% effective and can contribute to medication overuse headache. There are also opioid risks in terms of both addiction and the risk of medication overuse headache. And despite recommendations against opioid use for headache, a third of Americans with migraine still use opioids for acute treatment. Medicines are also not always ideal when people have comorbidities or pregnant or nursing. And so for all of these reasons, non-drug treatment options are really important in the consideration of treatment modalities for migraine. They can often be taken concurrently with medicines, and sometimes they address other factors that may be playing a role in a person's migraine experience, such as stress or anxiety. So after I finished my integrative medicine fellowship, I entered the field of headache medicine, and I was really struck by how in the field of headache medicine, there was this label of behavioral treatment options that were sort of non-drug approaches. And behavioral options in the field of headache had been studied for many years, since at least the 1970s, and looking at biofeedback, relaxation training, and cognitive behavioral therapy. So there was a lot of evidence, in fact, grade A level evidence, supporting their benefit in migraine. However, coming out of the Integrative Medicine Fellowship and labeling these non-drug approaches as sort of mind-body approaches, and you can see the list there, there's significant overlap between these mind-body and behavioral interventions. And one of the studies that I conducted during our Integrative Medicine Fellowship was where we actually looked at the prevalence of non-drug treatment options in adults with severe headaches. So using data from the 2007 National Health Interview Survey, we analyzed individuals with severe headaches and what modalities they were using. And I was really struck by how common people were using treatments like yoga, meditation even, with 17% of adults with severe headaches reported describing using meditation and deep breathing exercises. However, less than 1% of individuals with severe headaches were using biofeedback. So it seemed there was this large discrepancy between what the data showed in terms of the grade A level evidence for biofeedback and what people were actually doing. And it was especially interesting because at that time, there were no large clinical trials evaluating meditation in migraine. And so I was really interested to further understand and see if this is something that could be helpful for patients with migraine. And so this led to the pilot trial that I conducted when I was doing my headache fellowship. And so we conducted a pilot randomized controlled trial, and we used the intervention of mindfulness-based stress reduction. And one of the reasons that I decided to use this intervention is that it's a standardized approach. And so as a headache clinician, when I'm recommending treatment modalities for my patients, it's so helpful to have a standard approach that I can say, well, this is what the research showed for this modality, and this is the intervention. And we compared it to usual care. So it was a waitlist control group. And participants were able to continue all of their medications during the study. There were no dropouts or adverse events. And participants practice at home on average about 30 minutes a day. We found that migraines were less frequent, less severe, and shorter, although the only outcome that was statistically different on those three was the duration. However, all of the disability scores were lower. MIDAS and HIT6 are two headache-related disability measures that we commonly use in the field of headache. And you can see the moderate to large effect sizes from those, from the intervention. Self-efficacy and mindfulness also improved. And we did qualitative interviews, and results from theme analysis suggested that emotional reactivity decreased, pain catastrophizing decreased, and pain acceptance increased. And so this was a very encouraging study to suggest that mindfulness may be helpful. And it was interesting because this was a small pilot study of 19 individuals, but it received national media attention, as you can see with that Time magazine article. And I think that's for a couple of reasons. Number one, like I mentioned, migraine is so prevalent. Number two, people are really desperate and looking for additional treatment options for their migraines. And as you all know, mindfulness is something that is many people are interested in it, and the media is certainly very interested in it as well. And so it received this national media attention, even though it was a small pilot study. When we were trying to understand, how did this even work, we really hypothesized two potential mechanisms that mindfulness may really target, specifically migraine. So the possibility that mindfulness teaches individuals a non-reactive approach to life stressors, and stress is the #1 reported trigger for individuals with migraine. It's also possible that mindfulness teaches individuals to practice a non-judgmental awareness of sensory events. So rather than turning away from pain, mindfulness teaches individuals to turn towards pain. So being able to develop this sort of detached observation of their sensory experiences. And so we sort of hypothesize both of these mechanisms as potentially playing a role. However, we really don't know how mindfulness could help migraine. And one of the questions that I've had is, we think about individuals with migraine as having a headache threshold. And what we don't know is whether an intervention like mindfulness lowers the individual baseline or raises the threshold for where the migraine attack occurs. But in summary, we were very encouraged by our pilot study, suggesting that mindfulness may have benefits, but recognized we really needed a larger study. We wanted an active control group, and we wanted to evaluate mechanisms. And so this led to the development of the research that I'm going to now spend most of the time talking about today. So this was a randomized controlled trial that we conducted, and we called it Stress Reduction for Migraine Study. We were very intentional about the title because we did not want individuals to know that this was a mindfulness study. So we did not recruit individuals for a meditation or mindfulness study. We said that this was a non-drug study where they would learn more information that may help their headaches without medications. So when people would say, well, so what are we going to learn? We would say, well, it's going to involve 8 weekly classes where you're going to learn more information that may help your headaches without medications. So we really did not give much information at all in terms of the content of the courses. We also created an active headache education control group to match the time and attention of individuals in the MBSR group. We randomized individuals who had a migraine 4 to 20 times a month. So typically, episodic migraine is defined as 4 to 14 days a month of migraine. And we decided to expand it because recent research has demonstrated the huge month-by-month variability of migraine frequency. And so we wanted to include people who 1 month may have 15 days a month, and then 1 month may have 14. So really targeting episodic migraine, but including those who may have, a little bit of variability. We stratified by headache frequency, and we had blinding of myself, the data analysts, the QST, the quantitative sensory testing administrators, and I'll talk about that in a moment. And we attempted to blind the participants to which group they were assigned to. So they did not know what the 2 interventions were, so they did not know whether they were assigned to the active or comparator group. One of the reasons we really wanted to blind individuals to treatment assignments was to decrease the chance of dropouts for those who potentially got into the headache education study and wanted to be in the mindfulness. We also were trying to minimize group expectation difference and also decrease selection bias of only those interested in mindfulness. So since I had moved to Wake Forest, one of my colleagues at Wake Forest is Fadil Zaiden, and he had just finished conducting this research that I want to describe to you because we used some of the research that he had done and incorporated it into our study. So he had just finished conducting this study where he taught individuals to meditate and applied noxious heat to them while they were meditating, as well as perform brain MRIs during that. And what he found was that after individuals learned to meditate, they had decreases in their pain, both in less pain unpleasantness and less pain intensity. And I'll discuss those differences in a moment. But those reductions in pain were associated with increased activation in the anterior cingulate cortex, the insula, and the orbitofrontal cortex, as well as thalamic deactivation, suggesting that meditation-related pain relief was directly related to brain regions associated with the cognitive modulation of pain. And so when I've been really thinking about what is the mechanism, trying to understand how mindfulness may target pain and differentially affect pain intensity and pain unpleasantness was really interesting to me. And so I'll tell you in just a few minutes how we incorporated this into our study. So for our study, we had two interventions, the MBSR, which was the standard MBSR protocol, and we did not make any modifications for migraine. And then we developed a headache education curriculum that involved 8 weekly classes where individuals learned information about their headache. And our goal with this was to provide information without creating behavior change, which is very challenging, as you can imagine. We included individuals, like I mentioned, with 4 to 20 migraine days a month, and they had to have a diagnosis of migraine that met International Classification of Headache Diagnosis criteria. We wanted to ensure that they had a stable migraine condition, and so they had to have migraine for at least a year, be 18 years or older, and be available for the 8 weekly in-person classes. We also excluded individuals who did not have who had other chronic pain conditions, and excluded those with medication overuse headache, which means individuals who have 15 days a month or more of headache, and they use acute abortive treatments for a frequent number of those headache days. We also screened people out who had severe clinical depression using the PHQ-9, who had regular weekly or more often mind-body practice already. And you can see the other exclusions that we had there as well. We wanted individuals to stay on all of their current acute and preventative migraine treatment options. So this was on top of what they were doing. So they were able to stay on everything, but we did ask that individuals maintain medication stability throughout the duration of the study. So here is the research design. So we began by recruiting individuals over the phone, and then after they screened in over the phone, we did an in-person screening visit in which we consented them, and I did an evaluation on every single patient to ensure their diagnosis and eligibility. They then completed questionnaires at the study visit using REDCap, and then we conducted quantitative sensory testing measurements, which I'll explain in a moment. And then they began keeping headache logs. So they kept electronic REDCap daily headache logs beginning at the screening visit. And that 28-day baseline headache log really served as a run-in period prior to randomization. So we really used 3 forms of screening to assess their eligibility: the phone screen, the in-person screen, and the baseline headache log. Through their baseline headache log, we not only confirmed their frequency of headaches between 4 to 20, but also confirmed that they did not have medication overuse headache. They were then randomized into either the MBSR or headache education groups, and they were blinded. And then we had 3 follow-ups at 12, 24, and 36 weeks, and that's after starting the baseline headache log. So even though its follow-up was at 12 weeks, it was immediately after the 8 weekly classes. During those follow-up visits, participants could complete their questionnaires remotely using the REDCap function, but they did have to come in for the quantitative sensory testing measurements, and we also did a qualitative interview at 12 weeks. So the entire study duration was 9 months, and participants kept daily headache logs for their entire 9 months. Now, since the intervention involved groups, we conducted this research design for each cohort of participants in the groups. And so literally this was sort of a reiterative process where we would start screening for one cohort and get participants through the study and then begin recruiting for our next cohort. And so we conducted 7 cohorts to be able to reach our goal sample size. So this is the pain mechanisms that I described Dr. Fadel Zaiden using, and I want to take a moment and describe what this was. So we use this thermal heat probe to evoke pain, and individuals would describe how painful it is on this sliding using this sliding scale. And so we actually would hand individuals this ruler, and they would move this scale over, and on the back side it then has a demarcation for exactly what that rating is and how much that is. And so what we were able to do with this measurement is ask people to rate both pain intensity and pain unpleasantness, with the idea that pain intensity is the sensory component of pain, and pain unpleasantness is the affective or emotional component of pain. And the way we described this to participants was as if it is we asked them to think about it like a radio. As the volume of the sound goes up, that's the intensity. Whether or not you like the song on the radio is the unpleasantness and how much you like or dislike the song. And so we were able to distinguish both pain intensity and unpleasantness in this way through experimental pain. And so this this procedure was only done when individuals were migraine free. Now, this was an interesting clinical trial learning experience because the migraine period, as we are learning, is much longer than just the period of headache pain. Now we understand that migraine itself often is preceded by a prodromal period lasting anywhere from 1 to 24 hours. So a lot of people who do quantitative sensory testing in migraine do not include testing during the potential prodromal period. And so when we started this study, we said, you cannot have had a migraine for 72 hours prior to this testing. And we quickly discovered with individuals who had 20 days a month of migraine, having them be migraine free for 72 hours was nearly, on the given day that a study visit happened, was nearly impossible. So we changed this so that individual had to be migraine free the day of the visit. So we developed a very concrete treatment fidelity plan according to the NIH Behavior Change Consortium and template for interventions, and the template for intervention description and replication checklist. So use both of these to really assess and make sure we were looking at study design, and I mentioned both arms had the same dose. We also ensured that both instructors had a protocol manual that they used and checked off weekly during their classes. The instructors were the same for all cohorts for their intervention, but were different. So we had one MBSR instructor and we had one headache education control instructor, and they were experts in their given field. And then we ensured that the delivery was consistent. So for each cohort, the intervention was taught on the same day and time for both groups. The class days and time varied by cohort. And then we audio recorded the classes and randomly selected about a third of them for assessment. And we had high inter-rater reliability to confirm the content, the adherence, and the appropriateness of the instructors, as well as the therapist's fidelity. We also conducted credibility expectation questionnaires, client satisfaction questionnaires, assessed the therapeutic relationship with the patient-centered communication skills, and the working alliance inventory. Class attendance was monitored every week, and participants kept a daily log of home practice via REDCap. So recruitment. Everyone always says recruitment is such an important part of clinical trial research. What I didn't realize is how important it is to put money behind your recruitment strategies. So for this funded study that was a K23 funded study, most of the money that I had was spent on advertisements. And this was really, really important. And I learned a lot about advertising for migraine clinical trials. So we really targeted participants in two main ways. First, we wanted to recruit individuals who had a migraine diagnosis, and we used our academic medical center, Wake Forest Baptist, to recruit individuals both from our comprehensive headache program as well as referrals from other providers. And we discovered while we were running this trial that Wake Forest has a system, it's called Best Practice Advisory, where it's a pop-up. So we created a system where anyone who was seeing a patient in the Wake Forest system who had a migraine diagnosis, while they were in the patient's chart, this little pop-up box would come up. I don't know if you'll have these flu advisories, like make sure the patient's had their flu vaccine, but this would come up for migraine and would say, your patient has migraine and may be eligible for the stress reduction for migraine study. Do you think this patient would be interested? And if they clicked yes, then in my medical record, I would then be notified of a potential patient. So we got a lot of referrals, both directly from providers as well as through this pop-up mechanisms. And then we also directly advertised to the Winston-Salem community. And we really targeted the Winston-Salem community because of the in-person classes. And so you can see that one of the mechanisms we used for advertisements was social media. And so we created a video with our creative communication marketing team that we then posted on social media. I did a Facebook Live interview. I went onto our local TV to talk about our research study and talk about migraine. This picture in the far left is my research team. I piled everybody into my minivan and we went all around town putting flyers up everywhere. And we used a lot of tools that I had learned about from experts at the Osher Center. So we used a study cell phone so people could reach us at any time. We created a study email. So there was an email address that was specific to our study. And then Wake Forest has a research registry called Be Involved that we created a link for, and we created the link to be very short so that then on all of our advertising modalities, we were able to include that link. So we tracked closely our advertising and referral sources because we really did, in addition to the social media, we also gave lots of presentations. We put ads in the local newspapers and magazines. A lot of the local magazines and newspapers had email listservs, so we paid to have them be distributed via email. We also even did 2 weeks of television ads, and we put things up on the bus, and we really just targeted a lot of different modalities because we knew that we really needed to recruit a lot of patients for this study. And so when patients came in to their initial visit, I asked them, so how did you hear about this study? And this is the the numbers when we ask people, how did they hear about the study? And also we asked them when we did phone screens. And what was interesting was most people didn't know. Like most people said, I don't know. A lot of people said that they found it online through the Wake Forest registry. And so of the 199 people who did, we then went to the Be Involved, the Wake Forest Research Registry database to actually look at where those clicks came from. And you can see that a lot of the clicks, most of them came from Facebook. And then in terms of the recruitment from providers, we got over 1,700 referrals from providers through that pop-up mechanism in the chart. And then we also got over 100 direct provider referrals from all the presentations and information I had disseminated to providers across the institution. People would literally send messages or notes or emails to me, so it was a direct provider referral. And then we also did some medical record review as well that brought in some participants. We kept a track of the metrics of our social media to assess which flyer or advertisement was most effective. And what was really fascinating was across all of our social media advertisements, we were really targeting, like I mentioned, the Winston-Salem community, which has a population of about 250,000 people. Well, what was interesting was all of the views in each of our social media totaled over 450,000 individuals. And the impressions, or the number of times a post has been displayed on somebody's feed, was over 1 million. And so our social media really reached out to a lot of people. And I discovered that for our clinical trial, Facebook is a very effective tool for a couple of reasons. Number one, the average Facebook user and gender is the same as the average age and gender of patients with migraine. So, the average age of patients in clinical trials for migraine is around 43, and about 80 to 90% of participants who participate in clinical trials with migraine are women. And so that overlap really served us well in the effectiveness of Facebook for a migraine clinical trial. In addition, Facebook, as all social media does, has that sort of share feature. And so we discovered that almost everyone knows someone, family or friend, who has migraine. And so a lot of people would see it and then share it with somebody that they knew in a very rapid fashion. So here are the different outcomes that we assessed. We determined that our primary outcome would be migraine day frequency. And we determined this based on the clinical trial guidelines for conducting migraine for both drug and non-drug treatments. And we defined this with our migraine, we measured this with the red cap electronic daily headache log that people were keeping. And the outcome was assessed at baseline and then at the initial follow-up visit at 12 weeks. We also had a multitude of secondary outcomes that we were interested in looking at: disability, pain catastrophizing, depression, anxiety, quality of life, self-efficacy, and mindfulness, as well as the experimental heat pain intensity and unpleasantness. So in order to analyze our data, we grouped our headache logs into phases of 4-week periods of time and then modeled the migraine frequency across phases using a multivariable linear mixed model. And you can see all the factors that we included in the model. I do want to point out that cohort was one of the factors we did include in the model, since we were running individuals over different cohorts. And we estimated a goal sample size of about 88 participants to reach a difference of about 1.3 migraine days between groups. Because individuals were keeping their headache logs daily for 9 months, we did end up with some missing data, as you can imagine. And so we looked at our missing data in a multitude of different ways. The first was that we looked at individuals who completed at least 14 days out of the 28-day period, and then we based that frequency on that data and normalized it to a 28-day scale. And for those who did not complete 14 days out of 28, then we assumed all of their data was missing and used multiple imputation. We use multivariable linear mixed models for our secondary outcomes as well. And we were very clear in our manuscript that we did not adjust for multiple comparisons with our secondary outcomes, because we viewed the secondary outcomes as informative for future research. We also modeled our quantitative sensory testing for the evaluations that were done at 49 degrees Celsius, which was the hottest temperature. That equates to about 120 degrees Fahrenheit. So it's pretty hot. And I mentioned about the secondary outcomes were really considered exploratory. All right, so this is the exciting part. I can't wait to go through the results. So first, I want to give you sort of an overview of the study participants. And this is sort of an overview of when participants were recruited for the study. And I just want to point out in red there, you can see that we started the study in July of 2016, and the last study visit was in June of 2019. And so it really took about 3 years to conduct this clinical trial. The average cohort size was about 12.7. And unfortunately, because we didn't have an extensive amount of funding to conduct the research, for each cohort, we were only able to offer one date and time for the class option for that cohort. So when we started our first cohort, we learned this actually, because when we started our first cohort, we screened everyone over the phone, like, are you know, as eligible or not. And then we said, okay, now we're going to ask everyone who's screened in what day and time works best for them. Well, that just did not work at all, because not only were half the people that we screened in, we were not able to reach again a second time, but, you know, everybody's schedule was so different. So for cohorts 2 on, we determined the day and time before we even did the phone screens, so that when we were screening someone in over the phone, if they told us they could not come in on a given day or time, they were not eligible for that cohort. And then we said, but next cohort, maybe you'll have a different availability, and we would, if they were eligible and still interested, we would then call them for a future cohort. So here is the flow diagram, and I'm going to walk through this slowly and point out a couple of things. We had to do 1,691 phone screens to have our 89 participants randomized in this clinical trial. So this was extraordinary, and I have to say, when I created this study, I created the phone screen so that, in essence, we were using the International Classification of Headache Diagnoses to screen patients for migraine. And so in a lot of ways, we were diagnosing patients with migraine over the phone. And so when I began the study, I really thought, okay, I'm the only one who's the headache expert on the team. I'm going to have to do all these phone screens. And after 2 weeks of doing phone screens every day, all day long, I realized I needed some help. There was no way in the world I would be able to get this study done if I was the only one doing it. And so I created a systematic way of training students to be on my clinical team to be able to conduct the interviews, where I trained them in doing them and then watched and observed them doing interviews to confirm that they were able to conduct them effectively. We then did 157 in-person baseline evaluations. So most people actually were excluded at this phone screen stage. From the in-person evaluations, we then excluded 25 further, so 132 began completing their headache logs. And then we excluded another 36. And then we randomized 96 participants in our trial, but we used a modified intent to treat for our analysis for those who were randomized and attended at least one class and kept one headache log. So our modified intent to treat analysis was based on 89 participants. 45 were randomized to the MBSR group, 44 to the headache education, and you can see the analysis there. So let me take a moment and walk through this a little further. When we looked at the reasons for exclusion, lack of availability or interest in the in-person weekly classes was one of the biggest reasons for exclusion, along with not meeting eligibility criteria. Interesting, at our baseline screen, we had 129 people who screened in over the phone, but then no-showed or canceled their baseline visit. And then we had 7 patients at the baseline visit who had no pain ratings to noxious stimuli. So they were screened out because we wanted people, since that was an outcome that we were looking at, they had to have at least some rating of pain to that noxious stimuli. During the headache log, of the 132 people that were given a headache log, about 10% or 13 were not able to complete that baseline headache log. So when you look at this a little further, you can see that 91% of those who were screened at the baseline visit were excluded. 16% of those who were evaluated at the in-person visit were excluded, and then 27% of those who were given the headache log were then excluded. So only 5% of those originally assessed were included in that baseline visit. Were randomized into the study. 57% of those from the baseline evaluation. So our phone screen was really an effective way of screening people out of the study. And when we look at the reasons that people were not eligible for the study, interestingly enough, not having enough migraine days a month was our top reason for screen failure with the phone screen. Also, having too many days a month. A lot of patients have both migraine and headaches, and so even though all of our advertisements clearly stated, requiring 4 to 20 days of migraine a month, when we actually talked to them over the phone or even at the baseline visit, they actually had headaches every single day. And so we screened out people with daily headaches. And you can see the other exclusions there as well. So here are baseline characteristics of our patients. Most clinical trials I mentioned earlier have about 90% women, and this was true with our trial too. 91 to 93% of the participants in our trial were female. And most of the participants in our trial were white and had private insurance and also were employed full time and had a college or graduate degree. And what's interesting is when I compare this to the patient population I see in clinic, this is different. The average, for example, in my clinic for headache patients, about 65% have private insurance. So this was individuals who were more likely to have private insurance than even those that I see in clinic. Most participants had 9.5 to 10 days a month of headache, or about 7 migraine days a month. Now, we looked at a lot of factors and found that many of the patients that were interested in this clinical trial had tried a lot of prior preventive medicines, so on average about 3 prior preventive medicines, or about 5 prior acute medication options. So these were patients who really would be considered refractory to typical treatment options. And many of them had already tried a lot of prior integrative options as well. And anywhere from 56 to 71% had experienced a side effect to a headache medication. We also asked individuals how many triggers did they have, and most reported an average of 6 to 7 triggers, and about 70 to 78% of participants described stress as a trigger. And this was one of those inevitable things that happen in research that you don't plan. When we labeled our study as stress reduction for migraine in an attempt to mask the mindfulness intervention, what ended up happening was when we were screening people over the phone and we told them the name of the study, many people would say, well, stress isn't a trigger for me, so I'm not eligible. So a lot of people, because of our title, thought that if stress was not a trigger, then they would not be eligible. And it's an interesting question that we're excited to do some post hoc analysis to see if that in fact is true. But most people in this trial ended up having stress as a trigger. I do want to note that unfortunately randomization did not serve us well in equally distributing those on current prophylactic treatment. I mentioned to you that people were able to stay on their prophylactic treatment options, and unusually enough, only 40% of those in the MBSR group were currently on prophylactic, whereas 71% of those in the headache education group were on prophylactic. And this was statistically significant. So we did do a sensitivity analysis on our primary outcome to assess whether or not that was a factor, and it turned out not to be a factor. So in terms of adherence and fidelity and other measures, we were pretty impressed actually. Most patients attended classes. The median class attendance was 7 out of 8. And we defined a completer as attending at least 5 out of 8 classes, and 84% of those in the MBSR group and 82% of those in the headache education group were considered completers. And so in terms of developing a comparator group where individuals were engaged, we felt we had accomplished that. 73% of the individuals that began the clinical trial completed the study through 36 weeks, which is typical of interventions like this. And the fidelity. Individuals practice on average 4 days a week at home, and on the days that they practice on average about half an hour. And in terms of therapeutic relationship and program satisfaction, they were high in both groups. Now, interestingly enough, I don't know if others use the client satisfaction questionnaire. Both groups had high satisfaction, greater than 24, which is considered high. But the MBSR group was statistically significantly higher, but both groups were in the high range. And the credibility expectation was similar at both groups. We only had one participant report developed a squamous cell carcinoma during the clinical trial that we decided was unrelated to the protocol. So here's our primary outcome. Participants in both groups demonstrated a reduction of migraine days from baseline at 12 weeks without statistical difference between groups. And the decrease was about 1.5 to 2 less migraine days a month. In clinical trial research, less than 1 day a month is really considered clinically significant. And so both groups had an improvement. And this suggests that we did not see a difference between, or that MBSR improved more than headache education. We did a multitude of sensitivity analyses to assess whether or not there were other factors playing a role. So we did one where we assumed missing data were simply days with no headache, and that did not change the results. We did another sensitivity analysis where we included only complete or non-imputed data, and that did not make a difference. And then I mentioned the sensitivity analysis taking into account the difference in the prophylactic treatment across groups, and we fit a model using it as a covariate, and that did not make a difference. Now, interestingly enough, our secondary outcomes were very positive in terms of moderate to large effect sizes on a multitude of different instruments. So what I have on the left is the list of all of the instruments, and then the figure on the right is the Cohen's d effect size. And so you can see for many of these instruments, we had moderate to large effect sizes, specifically in pain catastrophizing, migraine disability, headache management self-efficacy, depression, and quality of life. And this was showing that MBSR had statistically significant improvements on these measures with moderate to large effect sizes compared to the headache education group. So now I'm going to show you the results from our quantitative sensory testing as well. So on the x-axis, we have both pain intensity and pain unpleasantness. And the straight line is the MBSR group, and the dotted line is the headache education. And the line straight in the middle is 0% change from baseline. And so those in the MBSR group had a 36% reduction in their perception of pain intensity and a 30% reduction in their perception of pain unpleasantness compared to the headache education groups. This suggests that individuals who learned mindfulness changed their perception of pain as measured with experimental pain after the study compared to before the study. So in summary, both MBSR and headache education improve migraine frequency. And so the question kind of comes, is this a positive study or is it a negative study? Both groups helped, but we did not show that MBSR helped more than headache education, which was our a priori hypothesis. Interestingly enough, MBSR participants had improvements in so many of our secondary outcomes and had decreases in experimental pain intensity and unpleasantness. And all of these secondary outcomes persisted out to 36 weeks, suggesting that mindfulness may help treat the total migraine burden. We were really surprised with our primary outcome findings. And it really comes down to, what is the best control for a non-drug treatment trial? And we really labeled our headache education as a comparator group, not as a control group. This was, not a benign intervention. It was an active intervention where individuals learned information that was helpful. And, information is power. And so this headache education intervention was effective, but only in affecting frequency. And that was what was really interesting to me also, was how did something change frequency, but not change all of the other outcomes that we saw with MBSR. We were also rather struck by the effects and the effect sizes of the intervention on the secondary outcomes, as well as the quantitative sensory testing outcomes as well. So, there are many strengths to this study. We blinded participants to treatment assignments. I did an evaluation on all patients to confirm their diagnosis. We used community recruitment for our study, so we felt that the study was generalizable and patients were able to stay on their medicines. We had a matched group, a moderate sample size with long-term follow-up and mechanistic information. But really one of the questions is did we really choose the right primary outcome? And it was very challenging to conduct this study when only one day or time was available per cohort. The study was also really lacked diversity in participants. And MBSR group had homework and the headache education group did not, so that was a difference. I just want to take a moment and describe sort of this review process. In conducting clinical trials, being able to disseminate the research is very important. And so there were a couple of things that were interesting for this process that I just want to walk through, and I can spend a lot more time after we're done in describing this. But, you know, the selection of journal was really, really important for me because I really wanted to target the right audience that would understand and appreciate that migraine is an important condition. Mindfulness is something that many people are interested in. And so the secondary outcomes have really value for consideration for future research. And so I really considered a lot of different journals. And then actually, when I decided on sending this to JAMA Internal Medicine, I literally went through the journal and found another article that had been published with a mindfulness clinical trial, and had that article up on my screen that I used as a model while I was writing the manuscript for this study. I also focused on the cover letter. So important. I have a friend who's an editor, and she talks about how the cover letter is like a missed opportunity for so many people. And I'll even show you the cover letter that I did. We had one editor and 3 reviewers, and our first round of review, we only went through 1 round of reviews, thankfully. But the biggest thing before I had submitted this paper, when I first wrote the manuscript, one of my mentors, Tim Hull, who I'm not sure if he's on this call right now or not, but he taught me about Isabelle Boutron's research on spin. And so I went back and, like, before we submitted it, I went back and rewrote the manuscript, because initially I sort of wrote it like, oh, both interventions, you know, benefit, and really then went back and wrote it to pull out that spin. And it really comes down to the question of hypothesis driven versus data driven research. And we were hypothesis driven research, and the results can help inform future studies, but our primary a priori hypothesis was negative. And so this was really important. And when we then, even after I felt like I had pulled out all the spin, that was still the main comment from our reviewers, was that we spun it too positive and we needed to take that out. And then the main results from this study are really showing that this is worthy of future research. And since I'm here now with you, I'm really excited to tell all of you who helped me learn how to do clinical trial research that one of the reviewers actually labeled this study, and in their comments, they said, this is really a state-of-the-art clinical trial. And so I've been dying to tell everyone who taught me how to do research that that compliment was given, because that was really one of the highlights of this research. So this is the actual cover letter that I did, and I'm happy to send it if anybody wants. But basically, I highlighted in it migraine impact, the rigor of the research, the unique study design, the worldwide interest in mindfulness, the impact of the results of this study, and then how, since I submitted this study during the pandemic, how mindfulness may help individuals with stress and migraine. So what was also very interesting was that Dan Turkin wrote a commentary, an editorial about this, commenting on the choice of primary outcome and the choice of control group. And I'll just read some of his comments that he had, because actually I agree with all of his comments. So one of his comments was, the primary outcome was negative, but multiple secondary outcomes are important to patients. Yes, that is true. Choosing headache frequency as a primary outcome is often done because it is done for drug trials and may not undergo the rigor of grant reviews. That is correct. I chose headache frequency because I wanted this study to be at the rigor of drug clinical trials. Was it the right outcome? You know, am I going to use headache frequency for future trials? Probably not. Then he also commented that disability and other patient-reported outcomes should be considered for primary outcome, and I absolutely agree. And in fact, in headache right now, we're working on changing our clinical trial guidelines for behavioral and non-drug treatment options to include disability as a recommendation for a primary outcome. Interestingly enough, you know, when we conducted this pilot study, we had a usual waitlist control group. And so in conducting this study, we wanted to elevate our control group and have an active control group. And one of his comments was that the absence of the usual care group made it impossible to estimate the effect of incorporating MBSR as treatment. And it was like, yes. But, you know, it made me laugh because I thought I was using an active control group to make the study more rigorous. And now you're going to criticize me that I didn't have a usual care control group. So it made me laugh. But in going back and actually looking at some of the research Dan Churkin has done, he has actually included an active control group and a usual care control group. And so that would have been great if I could have had the funding to do a 3-arm clinical trial, but this was funded with K23 research, and so that wasn't really possible. He also commented that headache education control group may have underestimated the effectiveness of MBSR compared with usual care, and that's possible. So I could spend really an hour talking about all the challenges in learning. I've mentioned some of them. The phone screen was really important, and I have pictures of the clinical trial teams that I've used. I began incorporating undergraduates on my research team and have found it to be an extraordinarily rewarding experience for teaching and incorporating undergrads on my research team, giving them an opportunity and exposure to clinical trial research. And I've even published about how using undergraduates on a research team can potentially increase the pipeline into neurology. Advertisements, you know, spending money on advertisements is very important, but we found out that some of the least expensive forms of advertisements, like social media, were most effective, and things like television, which were very expensive, were least effective. And then we really, for future trials, will take into account participant burden in terms of, you know, keeping a daily headache log for 9 months was very challenging. There's a multitude of other studies that have been conducted in the field, and I won't go through them here, but this research has dramatically exploded in terms of looking and evaluating mindfulness in the field of migraine. And it's really exciting to put our research in context. So in summary, there's really tremendous demand and interest for non-opioid options for migraine. Many patients and providers are really frustrated and are looking for other treatment options. And mindfulness may help treat the total burden of migraine, but we really do need more research to further understand it. Disability really could be and should be considered for a primary outcome. And, you know, what are the mechanisms for mindfulness-induced pain relief? This question is so fascinating to me, especially since our study data demonstrated the potential for mindfulness creating a shift in pain appraisal. And then future questions are, you know, how can we increase the reach of both these interventions and the research to include more diverse populations? So received a lot of research support, and I'm very appreciative of, and have had a lot of inclusion of a lot of different people to help conduct this research trial. This was definitely an example of team science at work, because this was not a trial that was conducted alone by any means. And I also want to thank all of you who have been such support and help in teaching me and how to conduct clinical research and how important this is. So thank you so much. And I'm excited to take questions now. So I'm going to stop sharing my screen.
Thank you so much, Rebecca. Just taking us through all of that. I so appreciate, you know, the rigor that you applied, you know, to this study, and you know, the thoughtfulness in terms of the study design and thinking about the mechanisms, and, you know, taking us through the fidelity and the recruitment and all of your lessons learned. So there's a bunch of questions, you know, in the QA. We don't have a whole lot of time, but so I sort of looked at them. I think if we can get to one or two of them, that would be great. So one of the some of the questions, you know, Julie talked about the population that you studied, and, you know, you had mentioned that many of them had private insurance. So this particular question was, someone did a recent review of migraine and severe headache prevalence in the U.S., finding that 34% had a high school diploma or lower, and 42% were near or below the poverty line. And so the question is really, are there differences in uptake of mindfulness as an intervention based on education and SES or SES? And is there a way to make it easier for people with migraine to access mindfulness?
Yes, this is such a great question. And I don't know if Paula Gardner is on right now, but in doing this research, this became very important of recognizing how this study was really was a non-diverse conducted study. And it made me realize, you know, when I was doing it, how that is a huge need, especially because the patients with migraine are diverse patients. And so I have actually, Paula Gardner has done some amazing work in this space of better understanding how mindfulness can be, how diverse populations can actually are very interested in mindfulness. And there are specific factors like class location and time of day and other factors that really inhibit uptake of interventions like this for individuals of diverse background. And so I've partnered, I'm really excited that I've partnered with Paula for my next clinical trial research that I just submitted an R01 for, because this is so important of targeting diverse patients, and Paula has expertise in this population and has been doing this research, you know, for many years of how can we reach diverse populations with interventions like mindfulness. And so it's very important research, and it's something that I'm looking to do a better job of in the future, because I don't think it's a lack of interest. You know, the first pilot study that I did when I was in Boston, I'll never forget, I had a patient of there, you know, it was a small study, so I knew all of the participants, and there was one patient who during the trial, like, her car broke down, like she had all these like major life events happen, and she loved learning mindfulness. And, you know, it's an N of 1, but I just will remember how, you know, she was someone who was of a low socioeconomic background and had discovered that, like, I think what we're finding is that people of all backgrounds are interested in this, but really, and this is sort of in a lot of ways in our current life and our world, this sort of self-care model has sort of been targeted to sort of the high socioeconomic population, but it's not because those are the only ones who are interested or needing of it. So I think when we talk about stress as a trigger for migraine, the stress that people in high socioeconomic factors, high socioeconomic backgrounds deal with is very different than the stress in people of low socioeconomic backgrounds. And so I think it deserves much more attention. So great question.
Yeah. So I'm really sorry, like we're over time. I wish we had the time to go through some more of these questions, but I just want to thank you again, Rebecca, for really a wonderful talk and some really wonderful work. And again, an example, you know, of kind of the rigor that we can apply to this field, and, you know, similar to the comment that you got from the reviewer in terms of state of the art. And there were a lot of comments, you know, in the QA, or just really applauding you for this work. So thank you so much.
Yes. So I'm happy to also, like if I can copy, I can respond to these questions, like type them up and send it, you could send it out to people, or I don't know if I can stay on and talk as well, but I'm also, I'd love to respond.
Yeah,
to
we can definitely, you
questions.
know, we'll have the questions and we can send it to you, and you can respond to them sort of offline.
Okay.
That'd be great. So just as I close, I just want to say very quickly the next 2 grand rounds that we have for the next 2 months. So Tuesday, April 6th, we have Dr. Eric Rosine, assistant professor in the Department of Family Medicine from BU, referring primary care patients with back pain to chiropractic care, barriers, facilitators, and implementation strategies. So that's going to be a clinical case grand rounds. And then Tuesday, May 4th, we're going to have a research grand rounds with Dr. Joseph Lascalzo, who's the chair of the Department of Medicine at Brigham and Women's Hospital, and he'll be speaking on food as innate drug source, novel strategies for drug development in the era of big data. So I hope you all will join us then. Thank you again, Rebecca, so much, and wonderful to see you again.